All right, we've got a really busy agenda today, but I'm going to say hello. My name is Claire Smith. I'm the Chief Operating Officer for the organisation. I'm actually in Merrion House today. I'm here on behalf of Phil, our Chief Executive, who's actually on annual leave, which is why I'm chairing this, because he would normally do this, because he really enjoys this meeting, as do I. We've got quite a few things to go through. We've got improvement patient pathways, and I know Tracy's going to come up next, developing and implementing Chemocare electronic prescriptions with Jenny. Then we've got enhancing the accessibility of organisational development with Richard, and then improving the resilience of pharmacy staff with Oliver. What we'll do is that we'll go through all the presentations, if that's okay, and then we'll hopefully have time for questions at the end. So we're going to have to, what are we at, 12:32. I think everybody's been given their timestamps, haven't they? So I'm sure our KPO, in true Leeds improvement method style, will keep you on track with timing. So, Tracy, nice to see you, and over to you, please.
Thank you, Claire. So hello, everybody. My name is Tracy Scanlon, and I'm the Service Manager in Older People's Medicine. And our presentation is on improvement patient pathways in the same-day emergency care in the Older People's Unit. So one of the challenges that we came across, the problem that we really had, we wanted to describe and understand. There was so much variance on the amount of time a patient actually spends within the SDEC unit. So we wanted to see how we could streamline and see what that variance was caused. So why were some patients in there 2 hours? Because that can vary between 2 and 6 hours. So the actions that we came up with, obviously I was on the Leeds Improvement Method course, which was what prompted us to take up something. I've been really, really privileged during this piece of work that I was really heavily supported with Helen Mercer, who's the project manager for SDEC. And on top of that, I also had really good involvement from Alex Diggles, who helped us with the project, and Katie Mallender, who was my coach throughout the session. So before we started to go through the time observations form that we used, what we did we met with the SDEC team to discuss the problems we were trying to address. We explained about the LIM work that we were going to undertake so that the staff were all brought into the process and were in agreement with what we were trying to achieve before we even started it. And then we agreed dates of when would be a suitable time to hold this improvement week, because obviously we didn't want poor staffing things. And we appreciate that that could have just happened, but we thought it was best to try and plan as best we could for that. During the week, we tried with the spaghetti diagram, which I'd found really useful during my sessions on the Leeds Improvement course. But as we tried that on the first day, we had several people doing it, and we just found that after even the first 2 patients had come through, we just found that was really difficult due to the amount of back and forth that a patient had whilst within the unit. It just got quite messy. I started to really struggle with it, and I just said, we need to stop this. So after several patients of trying to do it and realising it was becoming far too confusing, we switched and started with the time observation forms, which we then carried on using in the end, which were much easier. How did we engage the teams in that change? We'd met with them prior to describe the problems and the challenges, the length of time, in that we were trying to understand why there was so much variance in patients. And we were able to demonstrate where the delays were from the time observation forms in the patient pathway and how this impacted on patients, both from a length of time point of view, but also that created capacity issues, as if there was too many patients in the department, we then couldn't take further patients. So that's how we'd engage the teams. From the outcomes of the time observation forms, we then met back up with Alex and collated the information from, I think we had about 30 patients all in all. The evidence from the time observation forms enabled us to change some of the processes which were currently in place, which clearly were causing delays. Some of these were down to inefficiencies, but also we had duplication going on. So the time observation forms were really good in identifying that. We also identified we had duplication of tasks that was highlighted, and we could address this to ensure that staff were clear on their roles and responsibilities and who was doing what. We were also able to change the time that the medical review took place in some patients, and that again was a little bit linked to the roles and responsibilities because we just had different staff doing different things. So it meant that diagnostics could then be requested and completed earlier in a patient journey, as opposed to it being left till a little bit later when a patient had been sat there for an hour. And this enabled us to decrease the time spent in the unit for some of our patients. Unfortunately, we didn't have any metrics which we could prove before and after, and some of that is down to the fact that patients that attend the ESTEC unit are ward attenders, so it's really difficult to pull the information off PAS because they're not admitted and discharged, so it's a very manual process. We did have some basic recordings of how long a patient was in the department, but we've actually not got any metrics to prove that we've reduced that. What we have done is it's proved to us that we can reduce hopefully the amount of staff that are working in the department, and that will be a positive improvement, as we've realised that we've set a standard that a junior doctor would only need to see so many patients, so that will help with their training and development, and also ensure that a junior doctor can then be allocated to another area as opposed to ESTEC. Currently there's plans to look at how we move away from ward attenders, which I know that Helen's really involved with, so that any future work will enable us to have the metrics before and after our next improvement work. What went well for us, I would say what went particularly well was the collaboration and the huge enthusiasm of the team that we're working in. They were really, really enthusiastic about helping us to identify waste. It also brought to light that a lot of people weren't aware of KPO, and a lot of people have come forward since asking how can they sign up to do Lean for Leaders. So I think people's understanding of that has been really, really important. It also identified several staff have worked in the unit for a long time, and as we're all very aware, it's just business as usual because somebody's always done it like that. So I think seeing how we were working and feeding back to them then prompted them to think there are probably better ways of looking at it and what we were doing, and they're quite keen to be involved in that. So I think that's a really positive. Lots of ideas were generated by the team during the process, during the feedback sessions, which I think will lead to further improvement work taking place later in the year. What would we do differently? If we were going to do some of the work again, I'd want to maybe narrow down what we were trying to measure. I think it was probably one of the first pieces of works I've done in ESTEC, and we were trying to measure the length of stay, and I'm not sure whether the whole process from start to finish was kind of a little bit too big. We might want to narrow down last time, is there a specific part of that we want to look at? So have we identified that somebody coming into Clark into then diagnostics, would we just look at that as a time observation and see how we can reduce that, as opposed to the whole stay might be better, but it's something that we can take into consideration and discuss as a team. The key learning, I think it's that staff need to absolutely be aware of the project and brought into it. But at the same time, what we found during the project was that some staff were so enthusiastic, even on day one, they found stuff that said, oh, this is probably not the best way we could be doing this, and then going off themselves and making improvements, which is really difficult because then some improvements were actually starting to take place during the improvement week. So therefore, we wouldn't, if we were tracking that, we wouldn't be able to see the overall effect. So I think it was just at the feedback session, what we said to the staff is there should never be the improvements made there and then. We should identify what improvements can be made and then decide which we want to take on as a team, and then work out the process for improving them, as opposed to staff being really enthusiastic and just tweaking things as they go. And our next steps for improvement, since we completed the improvement work, ESTEC Older People's Unit has now merged with acute medicine due to the work on the first floor being done. So I think until that's open, there's already been several changes because the teams have had to merge, which has been quite a big sort of thing to tackle. So I don't think there will be any further work done, improvement work, until we move into our new unit, which will be hopefully in November this year. But I think some of the improvement work is already underway and has been implemented, which I think has helped with the merger of the two units. And hopefully when we get up to the co-located unit later on in this year, we will continue as a unit, as a combined unit with acute medicine, to do the improvement work together and move forward from there.
Thanks very much, Tracy. It seems such a shame to only have 5 minutes to talk through something that's had been so impactful for our patients. But thanks very much for that. And we'll,
no problem.
So we'll take questions at the end.
Thank
you. I'm going to hand over to Jenny, who's got a very long job title, it seems. But I'll hand over to you, Jenny.
Hi everyone. So yeah, my name's Jenny. I'm the team leader for the chronic pain and neuromodulation service for the trust. And my project for Leeds Improvement Method was to design, develop and implement Chemocare electronic prescriptions for our intrathecal pump service. So the challenge that we have is we have a high risk intrathecal service, which is an implantable medical pump. And it's a complex process from prescription to administration. Our service works across 3 different hospital sites, and the prescriptions were written by the consultants or a non-medical prescriber, ordered by a pharmacist, made up in aseptics, and then we refilled these pumps on 3 different hospital sites. So it was quite difficult to organise and arrange this. eMeds wasn't an option, unfortunately, because we're effectively an outpatient service. So this was our problem or our challenge. So as a result of this, we were looking at ways that we could improve the process, make it more streamlined and actually safer, because we were having to transfer prescriptions from one area to another, from one site to another. So we certainly thought that there was a way that we could make improvements to make it more efficient, but also a safer service as well. As with any change, I knew it was really important to get the team engaged. So the actions, the first thing that we did was had a meeting with the team to, I guess, identify what some of the issues are and where we could make some improvements. In terms of the lead improvement method and the tools that I learned, I attempted to do process flow mapping, and for some reason found that really difficult. So I guess I cheated a little bit and adapted this way. I appreciate the flow chart on the right is very small and you probably can't read it, but the reason I've included this is to show you that effectively how complicated the processes were. So if you can see, the different colours are the different people and roles who are organised with the processes, and in the red shows you actually where there are areas of waste and where we could improve things potentially. So we did this as a team, and I also did some timed observations, which was quite difficult, again, because the processes are on different sites by different people, but that was really interesting to do those timed observations and see how long these processes were taking us. So we then met with the Chemocare team, because I'd heard that they'd done some really good work with the chemotherapy. We discussed the current issues with the Chemocare team and reviewed their current processes to identify if this was something that we could use within our service. We then met and have met on a few occasions with the Chemocare team and within our team, and developed and designed 17 prescriptions, which was really time consuming, but we had to do a different prescription for each of the combinations and drugs that we use for the service. We've written a standard operating procedure to make sure everybody knows the processes and who's responsible for what. We've met with the medicine safety group which I'll talk about one of the problems and the reasons for that in a minute. We've also only this week met with the medicines prescription group, and I'm really pleased to say that the processes have all been approved, and we should be ready to get going with the prescriptions soon. And the other thing we've got left to do is to train the staff on the Chemocare system. So the outcome, again, I appreciate this is a very busy slide and I don't expect you to read them, but really it's to show you that the flow chart on the right hand side, I've highlighted in yellow all of the areas and things that we were doing that have been the time and the efficiency and the safety has been improved by using Chemocare prescriptions. As I said, it involved a lot of walking from one place to another, different sites, and so this really will significantly reduce the waste from the service. And on the left hand side, again, it is quite small, but that is one of the prescriptions that we have. It's going to reduce room for error because there's now a standard prescription. So yeah, there's loads of really positive improvement, hopefully, when we're up and running. What went well, the team, I think because we got the team involved, everybody was on board and really saw that there were some, benefits of having electronic prescriptions. The team, we had to work with the Chemocare team, with our pharmacists, with our consultants, with aseptics team. Everyone worked really well together and were really helpful at getting this process up and running. And once we developed a couple of the templates, which was really hard to get it right to start with, it was quite easy to then design the rest of the charts. Last slide. As I said, designing the charts initially was complicated. One of the biggest challenges was that the Chemocare prescriptions, there's a template for them, and there were certain things that we were unable to change in that template. So the biggest issue that we had is that, I don't know if you saw at the top of the chart, it's a cytotoxic parental chart, which is not what the intrathecal drugs are. So this was one of the reasons we went to the medicine safety group, and we went to them with this, and they agreed that although that wasn't ideal, that we'd put enough safety things into the prescriptions, and we're a small team, so it was to reduce the risk from that perspective. I think it would be good to have more of the team involved in designing the charts and the processes to understand the complexity of it. Some of the team members who were perhaps less involved had little understanding really of what we were doing and why. And the last thing is that because we are dealing with controlled drugs, this made the process quite complicated, because we had to obviously consider the controlled drugs rules and regulations for the trust as well. So that's everything. Thank you.
Thanks very much. I was able to see some of the stuff on the flow chart. So but again, we'll come back at the end, Jenny, if that's okay. Rich, can I hand it over to you, please?
Of course you can. Yeah, good afternoon, everybody. My name is Rich Ellis. I'm here to share with you the work that we have been undertaking within the Organisational Development team to look at how we commission work into the team and how we look at work requests, but also as well how we also apply the Leeds improvement method in the work that we do as well throughout our practice. So the work that we were looking at really started off by understanding the work that we have on and how we manage that. Last year we dealt with 128 interventions within the OD team, which is a very fine art resource, but it was one that we wanted to really to get an understanding as to what we had on, understand how it came into to the team and how we could then manage that. And as you can see, hopefully, again, once again, another quite busy slide here, but we started to look at how we could standardize our work, our daily practice, and also understand how we could then improve the OD interventions but using thought leadership and space as well for continuous improvement, and having continuous improvement embedded in the practice. And then it's something that we do it as a routine anyway within organisational development, but understanding how we could also then apply that with the practice and our interventions that we were delivering. So within there, we've also got the OD production board, which gives us the ability each Monday morning to understand the work that we've got on, but also to understand the work that can be closed down. And it tells us at any given stage, really the intervention where it's up to, and also the work that needs to be carried out as well. It also gives us that opportunity on a Monday and Wednesday as well within our team huddles for that thought leadership process to take place, to understand shared learning as well, but also to understand how we can reduce waste in various aspects of the work that we do. And one of them being is actual waste of talent, to ensure that we've got talent aligned to the right interventions, to ensure that we're giving the correct service in an efficient way as well. So understanding really what we were doing as a daily management and a weekly management gave us that ability then to start to map out. And again, another real busy slide. But hopefully what you can see here is the end really, or the beginning, so to speak, of how we actually commission work in. So we wanted to use the spaghetti diagram to actually map this out. And it gave us the ability to have a look at it from a holistic perspective, to understand that the key areas, areas where there was blockage, areas where there was a waste in overproduction, where there was a waste of overprocessing, and also, again, a waste of talent, understanding where we could actually align the talent to the right areas. So this was an ideal opportunity for us to be able to map out. And it's one, if I'm honest, that it continues to develop. Because as you can see from there, it does, you can see the busy areas, and we've started to map them out with the icons, started to use the labeling, and we use this now on a weekly basis as part of our huddles to understand where in the map a particular intervention or a particular work request, with a view to actually reducing the time down. So from the work that we've done so far, we've been also having a look at the systems that we use. And the previous slide that I demonstrated, we were looking at the OD production board, the OD tracker board, and we've also got individual Trello boards as well. I think with this particular slide, what I want to be able to do is to be able to demonstrate that we've reduced the systems down. So whereas beforehand we had 3 systems, now we've reduced that down to 1 system, which gives us the ability to be able to again look at a snapshot where we are with a particular intervention, who needs to be involved in that. And again, this is discussed on a weekly basis. In addition to that, the outcomes that we've been looking at, for us, the Leeds improvement method has been a wonderful addition to our practice, because it's given us that ability to be able to view the work that we do, not just when we're looking at commissioning work, but also how we work with other teams as well, and how we can introduce Leeds improvement method through our OD practice as well. So creating that environment for people to be able to challenge and to understand the importance of continuous improvement as well, by providing that holistic approach, but by also asking those 5 whys and various other interventions as well, and methods. Really, the outcomes from that, I think it is, for us, it's about how we embed LIM into all our practice in every aspect of it. We've taken on board a number of areas where we've learned from our mistakes, and we're developing as we go along. I think the key area for ourselves is being patient and understanding that the practice that we put in place, the interventions that we put in place, will take time to develop, but we need to be focused on that development and understanding, using the PDSA model, what's working well, what's not working well. So understanding and being patient, creating an environment where we're open to new ideas where potentially we've explored them in the past and it hasn't worked, may work now, using technology as well. But also as well, that the streams of thinking, it's the mental valleys, is that working with individuals who are finding it quite difficult, quite challenging to move forward with the new ideas and new ways of working, and how we can best support them and creating that environment for change as well as we move forward. So loads of learning that we've taken from it, and we continue to do so as well. Hopefully I've got that 5 minutes in there.
Thanks very much, Rich. Okay, so we're going to finish on Oliver, so improving the resilience of pharmacy staff. Are you there, Oliver?
Yes, I'm here.
Brilliant.
Hi, good afternoon. My name's Ollie. I am the Advanced Clinical Pharmacist for eMeds, which is our prescribing system, electronic prescribing system within the Trust. So my role, essentially, I'm essentially a middleman between the technical and the clinical teams to make our prescribing system safer and more effective. As I've said, as the project aim says, so the aim of this was to improve the resilience of pharmacy staff to deal with unplanned eMeds downtime. So couple of trusts across the country, so Guy's and St Thomas's and then the Leeds Mental Health Trust have over the past year have had periods of unplanned electronic prescribing system downtime, and the consequences of this would be significant to our organisation. So not having no PPM or eMeds access for a prolonged time would cause a massive impact on our clinical pharmacy services, but also pose a massive risk to patient safety. And kind of hearing some of those stories made me think about, well, actually, it's been a few years since we've had some unplanned downtime at Leeds, and I have a feeling that actually, if systems went down, it would be chaos, and a lot of pharmacy staff really wouldn't be sure on what to do. So I thought, actually, we maybe need to have a review of this and just review our processes and think, lots has changed over the past few years post-pandemic. Is there anything we need to look at and review in order to make sure that if the system goes down, touch wood it wouldn't, that actually our processes are in order, so we know what we're doing, basically. And so this was just focusing on pharmacy staff rather than nursing and medical staff for now. So what to do? The first thing was to basically kind of go out there and see what resources were out there. So generally, if eMeds goes down, there's laptops where you can print paper charts, but there are a lot of other resources that we need, so paper forms and stuff like that. So I kind of went out there and kind of spoke to a few people, what would you do? And there was quite a lot of worried faces that I was met with. And I then had to think about, well, how might we simulate this environment of downtime? It's unethical, it's immoral to we can't just take down the system. So what could we do? So I thought about running a simulation session. So the picture in the top right here, it was a bit of a doomsday session. So I pulled some people into a room. We got 4 pharmacists, we got some pharmacy technicians, I got a nurse involved. Our lead improvement specialist came in. And I kind of said, right, eMeds is down. There's some paper charts. Go and do what you do normally. And we kind of took some metrics along the way, and then kind of sat down with people and just kind of had a bit of a thinking process about, what is it that we do if it went down. So alongside of that, I reached out and spoke to some other trusts. So there's no point in reinventing the wheel. So I reached out to colleagues at Guy's and St Thomas's and said, you've had 2 weeks of downtime. What did you learn? And they sent me a whole list of their lessons learned. And so that was really, really useful. Some of the tools that I used along the way, so process mapping, it's quite hard to plan out because you can't recreate it exactly. But I went through some of those processes and also used some other tools such as like Cotters and things like that. So what metrics did I look at? There's a few different ones. Again, it's quite hard to measure some of them, but one of the most basic ones that I did was just looking at the morale of staff. So I just asked staff before the session a really simple question of how confident do you feel that you'd know what to do if eMeds went down? And there were some worried faces. Interestingly, after we'd done the session and they thought about all the things that they need to consider, a lot of them then reduced their initial score because they were even more worried about what happens, but actually knowing, kind of going through some of the stuff, that they felt much more confident that they'd know what to do if it went down. So what went well, I thought the stakeholder analysis was good. Reaching out to other trusts was really beneficial. These things are really hard to recreate, so actually going and speaking to Guy's and Thomas's, what went well, what didn't, was really, really valuable. And then the second bit that went well was the simulation session. Was brilliant. Going into it, I thought this could be an absolute car crash. This could be terrible. But actually, the staff were brilliant. They were really engaged. They provided amazing feedback and some suggestions which I hadn't considered. And having people in different roles involved in that was really important. So what would I do differently? The first thing I'd put. Sorry to Jimmy and the team, but I'm going to put this back and say, initially there was a mental valley by the LIM team, and that actually when I suggested this project, they thought, oh, Ollie, this is quite a big project, but maybe a bit too much to focus on for here. And so I thought about another project and then went back to it. And actually, what Jimmy had said is just kind of just look at your scope. So just focus on pharmacy staff, and that actually was a really valuable project to look at. Next steps, where do we go from here? So I think in doing this, we need to think about bigger across the trust. So we need to think about our nursing and our medical staff. You know, it's been 5 years since eMeds has been up. So there's a lot of staff in our organisation that have never prescribed on a paper chart, and they don't know how to do it. They don't know that, you know, if they go to prescribe, allergies won't automatically pop up and things like that. So we need to consider that. So I'm meeting the head of resilience next week, and so we're going to have a discussion there about how we think about other staff. Next is to share learning. So I've got some really useful kind of findings from this, and so I want to share it with other trusts across the country. So I've reached out. We've got an e-prescribing national masterclass, so I'm planning to kind of talk about it there and kind of share some of the learnings that I've got. And then finally, just apply some of the principles to a bigger project. So I'm planning on, I'm just about to start leading a project on getting all of our paper infusion charts onto eMeds. And so there's a lot of the tools that I've learned in the LIM intermediate I can apply to that. So I think that will really help that project when it gets going.
Thanks very much for that, Oliver. I was just about to put something in the chat about making contact with our head of resilience person when you just mentioned it there. There's a huge amount of work. We've got such a reliance on our technology now, and we do need to make sure we've got good business continuity plans in place. And we are actually planning a tabletop. I'm the emergency accountable officer for the organisation, which is why I have such a real keen interest. My eyes really lit up on that. And we're planning on a bit of a doomsday tabletop exercise, Oliver, where we overlay multiple failures across the organisation. We've got great IT systems and support from DIT, but we know that we have vulnerability. We have vulnerability there, so we're going to overlay that and just sort of like build and build and build. So if you please do speak to Helen, say that you actively want to be involved in that, because I think it could be a really great learning thing for us.
Yeah, and I think you made a point about connecting the different systems
exactly
is where it kind of goes down.
Because if that goes down, PPM goes down, PAS goes down, what how are we going to provide safe care for our patients? So things that keep me up at night, I would say, Oliver. I'm really conscious of time, but we've seen some really 4 brilliant presentations, all very different as well. Can I just ask, does anybody have any questions? There are clearly comments that have been happening in the chat as we've been going along. Are there any questions from anybody at all at this point? No, there's no hands up, so please do read the chat because there's been some really great comments in there. I do think that every single one of those presentations that we've had today, all using the Leeds improvement method, but all using those tools in different ways and different sections of that in order to be able to improve the experience of our patients, but and also of our people and our teams, and using best use of resource. I think the more and more we just make this, and it's one of the reasons I like Rich's slides, is that it's just our business. This is our business in terms of how we review the way that we work, and I think the more we do that, Tracy's work, that what was shown there, the flow charts around the Chemocare, those sorts of things, it really does start to help us start thinking about how we reduce waste for our patients, waste for ourselves, in terms of how we're using our time, which is really precious at the moment. People are busy, and we want to make sure that they're using that time to best effect. Jimmy, do you want to come in?
Thanks. Very brief. It's kind of echo what you said, Claire. I was just going to say that the diversity of the application of the method, how people have adapted the concepts to make it work for them. That's kind of the message I want to reiterate. There's fantastic work there. Spread the word. There's something for everybody in this, and the more that we can get that out there, that it can be just part of how you go about your work rather than another thing to do. That's probably the key point. Thanks, Claire.
I'd agree, and with that full stop from Oliver at the end there, it's not just trying to make a better place to work, but a safer place to work as well. So brilliant. Thank you very much, everybody. Take care. Bye.